Okay. A very good evening to all the participants from the Asia side by joining our FATS Nose by FAT webinar today. Today, our speaker is Dr. Dean Toriumi from the USA, and our moderator for the night is Dr. Eduardo Yap from Philippines. So, thank you very much for both gentlemen to spend their valuable times for tonight. Today, this is the leading up webinar to the upcoming Nose by Pets, which is going to be held in Bangkok, Thailand on July 17 to 19 of this year, 2026. And as you can see on the screen, these are the list of the prominent rhinoplasty surgeons around the region and from America, Dr. Saban from France, and Dr. Goxel from Turkey. Okay. Without further ado, let me pass the baton to Dr. Eduardo Yap as the moderator of the night. Please, Dr. Yap.
Thank you, Eddie, for inviting me as a moderator. And we are pleased to have Dr. Dean Toriumi with us. I can't see Eddie, the curriculum vitae.
The CV for Dr. Dean Toriumi. Yep.
Yeah.
Yep.
Okay. Yeah. Dr. Dean Toriumi is a professor in the Department of Otolaryngology, Head and Neck Surgery, and is the head of the Division of Facial Plastic Surgery and Reconstructive Surgery at the University of Illinois at Chicago, a board-certified facial plastic surgeon specializing in rhinoplasty, blepharoplasty, rhytidectomy, and several other cosmetic and reconstructive surgical procedures of the head and neck. He completed the 5-year residency program in otolaryngology, head and neck, at Northwestern University Medical School, and has also completed 2 fellowships in facial plastic and reconstructive surgery. He is a past president of the American Academy of Facial Plastic and Reconstructive Surgery. Dr. Toriumi's primary interest is in aesthetic and functional plastic. Without further ado, again, Dr. Dean Toriumi, a world-renowned facial plastic surgeon, and you can have the floor now, Dr. Dean.
Okay, I'll share my screen here. So I'm now with Rush University, no longer with University of Illinois. So I'm going to spend a little time today. First of all, I want to thank Eddie and Dr. Yap. It's a pleasure being here and this preparation for the big meeting in July. We're very excited about this meeting. I'm going to just talk a little bit today about Asian augmentation rhinoplasty using both structure and preservation. As you all know, when we deal with the Asian rhinoplasty patient, they frequently require augmentation of both the dorsum and the nasal tip. In my practice, that typically requires the use of rib cartilage. Even though there are many different options for augmentation, which we'll talk about today, the structural techniques have been the same for the past 35 years. Asian patients tend to have a very weak septum and need structural support, particularly in the nasal tip area. So typically for this type of grafting, I'll use a caudal septal extension grafts fixed in some way to the existing septum. Now, the drawback here is it does create somewhat of a stiff nasal tip, and we discussed this with the patients preoperatively. In some patients who don't want a really stiff tip, we can use septal cartilage as an extension graft, and we can sometimes splint it with some ethmoid bone. That is also a very good alternative. I like to use some type of extended spreader graft to stabilize the caudal septal extension graft. It keeps it in the midline. It's very effective. And then for the actual nasal tip contouring, I typically, in Asian patients, will use a shield graft with articulated rim grafts. I don't do this in Caucasian patients. This is exclusively done in my practice in the Asian patient population with the thicker skin. This is the configuration that I use with a shield graft with two rim grafts sutured to each margin of the shield graft. Here's a patient who's a good candidate with very thick skin, very low dorsum, very short nose with high arched ala. So this is a very difficult case and does require use of rib cartilage. So in this patient, because of the low dorsum, uh, we're going to use a large dorsal graft. In this case, I used an onlay graft, but in later in the lecture, I'm going to focus more on preservation techniques using a push-up technique. You can see the tip cartilages are very weak, very soft, which is typical. So for the nasal tip, we first put in a caudal septal extension graft, and then we place a shield graft. And then we put in lateral curl grafts to stabilize the cranial margin of the graft because it's very important that this graft doesn't rotate cephalically because that can create a problem with the tip shape. And in these patients, we want to actually create counter rotation and lengthening, this patient in particular. I suture perichondrium over the nasal tip for camouflage so that the shield graft doesn't become visible over time. And then we place the articulated alar rim grafts to support the alar margin. The alar margin support's very important. Otherwise, you can get alar retraction, and she already had some degree of arching of the ala, so she's at particularly high risk. You can see how we pull the rim grafts into a pocket made on both sides in the premarginal vestibular skin. And again, we don't do this in Caucasian patients. We do this just in the Asian patient population. Now, because of the amount of augmentation, we're going to have a little tension on the closure. Here, I'm suturing these rim grafts into the depth of the pocket so they don't become displaced. And then we close the incision with a subcutaneous suture. We put a big dorsal graft because we did a lot of augmentation. And then we put composite grafts in for the alar margins because I don't want to have any arching of the ala or alar retraction. And then here she is 8 years post-operative. You can see that she has really improved dorsal aesthetic lines, correction of her alar arch. On lateral view, she has good projection, good dorsal height. Here's her three-quarter view. Base view shows good triangularity of the nasal base, and then the close-up frontal view shows much improved dorsal aesthetic lines. This is a unilateral cleft patient who has underprojected tip. And so in this patient, we again use rib cartilage. You can see we put in some lateral curl grafts, and then we put in a shield graft and then support that with the lateral curl grafts. And then the angle off the midline with respect to the caudal margin of the lateral curl is very important to prevent the retraction of the ala. And her angle is favorable at 45 degrees. Anything less than 45 degrees, we don't need rim grafts. So no rim grafts in this patient. But we did a Z-plasty on her cleft side to correct her alar insertion issue. Then here she is a year post-op. We can see that her symmetry of her nose is improved. We have a significant increase in her tip projection. I also did a chin implant on her. Here's her three-quarter view, good symmetry of the base view, and then good improvement on the frontal view. Now, there are some Asian patients who have dorsal humps. This particular patient here shows a little bit of an S-shaped hump with an underprojected tip. She also is a unilateral cleft patient with a deviation. So in her, I did a more classic type of foundational or a surface technique with a low strip. So I used a low strip to straighten her septum in combination with an Ashita. an original Ashita. So we harvest rib. On her, we used a premaxillary graft because of her deficiency due to her unilateral cleft deformity. So here's the shield graft. In her, I used a low strip in combination with an Ashita without cartilaginous. Here you can see I'm doing the Ashita technique where we free the upper lats from the upper aspect or the leading edge of the mid vault, and then we're going to remove the bony cap in this situation. There is a method where you can keep the bony cap. So I make cuts in the bone to allow me to move the bony cap out of the way and then basically lower the dorsum using these type of surface techniques. So we isolate the bony cap and then we can push it down. And then from below, the whole bridge gets pulled down using the low strip. And then we take this straight saw and take off the redundant bone. So in essence, what we're doing here is removing the bony cap, removing the redundancy in the lateral nasal bone, and then suturing the low strip into position to straighten the septum and to reduce the dorsal hump. So here we're taking out those segments of bone. Now you can see the hump is reduced. And then we're going to go ahead and do some osteotomies, lateral osteotomies to straighten the nose and also to get a little narrowing of the bony vault. So this creates the narrowing, the straightening, and then we swing the low strip. So here's the septal flap gets rotated and sutured into a notch in the nasal spine. So this removes the dorsal hump and also allows us to straighten the nose and straighten the airway. Here she is a year post-op. You can see her nose is straight. We've gotten rid of her dorsal hump, projected her tip, three-quarter view, base view, and then the close-up frontal view. Now, the technique that I like, I've been using since 2019 is use of a subdorsal cantilever graft to perform a push-up. And the reason why we do this is because some of these patients who we do large grafts on the dorsum, as you see in this image, you can see that there's a little visibility of the graft, the edge of the graft, particularly in thinner skinned patients. So what we're trying to do is preserve the natural dorsal aesthetic lines and create a very natural looking dorsum. And so the thought is maybe we can push the dorsum up from below instead of moving the dorsum down as we do in patients with dorsal humps. So it's preservation technique, but just going in a direction to augment the dorsum. I published this back in 2022. We call this a subdorsal cantilever graft. This was in facial plastic surgery and aesthetic medicine. So there's two types. There's a type A where we don't raise the radix, and there's a type B where we actually move the graft through the radix bone cut and sits on top of the frontal bone and actually raises the radix. So then you get dorsal and radix augmentation, which is what we typically need in the Asian patient population. So this allows us to elevate the dorsum using just movement of the bony vault. I don't use DCF. I don't like DCF. I think you don't get the control you really need. I want to create very defined dorsal aesthetic lines, and that's why my preference is this technique at this point. Patients who don't want major increases in dorsal or radix augmentation, we can use the type A. This patient just needed a little bit of radix augmentation, so we use a subdorsal cantilever graft type A that remains below the dorsum and raises the caudal nasal bone and the mid-vault. So here you can see after the tip work's done, the dorsum is low, so we take this subdorsal cantilever graft. This is type A, so it goes underneath after we completely release all of the attachments. So we do bony cuts and then we do lateral keystone release, ballerina maneuver, and you can see here how the dorsum is elevated. And then here's the patient. She's 4 years post-op now. She has really very natural looking dorsal aesthetic lines because the only thing that's been elevated here is her mid-vault and caudal nasal bones. On lateral view, she has really good tip projection, elevation of the dorsum in a very natural manner. Here's her three-quarter view. Here's her base view and close-up frontal view. So what's nice about this is there's no risk of a visible graft because you're not using a graft on top of the nasal bones. You're using a graft underneath the bones to push the bridge out for augmentation. Now, the type B graft is used most frequently in the Asian patient population because I do want to raise the radix. And so you can see how the cranial end of this graft goes through the radix osteotomy and sits on top of the frontal bone to raise the radix. So here's a patient with an extremely low radix. She has no nasal bone projection, so she can't even wear sunglasses, and that's a major, complaint to these patients. There's no place to sit the glasses on their nose. So in her, we harvest the eighth and a segment of the ninth rib. And here we put in a caudal septal extension graft. And then this is the subdorsal cantilever graft with a shield graft with articulated rim grafts. So the first step is to perform a release of the mid-vault and the bones from the septum. So here I'm taking scissors, and as you would in a Saban high strip, we make a very high cut on the septum to release it from all of the septal structures. So it goes all the way up to where the radix bone cut will be executed. Then you can see an endoscopic view of that cut. You can see how the septum's now been released from the undersurface of the mid-vault. You're looking up at the mid-vault. So then we take a curved Sercus osteotome to make our radix bone cut because the bones are so low, a straight osteotome will not work. You have to use a curved osteotome, so we go way up high where the frontal bone is located, and then we perform a high radix bone cut and leaving a shelf, and then we go way up high over the frontal bone. I'm using my finger to palpate as the osteotome passes through the bone onto the frontal bone. So I make two cuts, two perimedian cuts with this curved osteotome. I do this cut first because it sets the stage for the other bone cuts. So once we do that, we'll go ahead and we'll carve our subdorsal cantilever graft because we want to allow it to soak a little bit. We leave as much of the perichondrium attached to the graft as possible because the perichondrium helps with vascularization, but more importantly, rapid fixation. So now we're going to place our caudal septal extension graft, and here I'm doing a lateral keystone release, a ballerina maneuver, Goxel's technique. And then we're going to do here the septal extension graft. So we put splinting grafts, we put our caudal septal extension graft. That's the subdorsal cantilever graft. So now I'm just elevating the dorsum, and I take the subdorsal cantilever graft that's been carved to be narrow, very narrow along the leading edge because we want to narrow. Well, we don't want to make the bridge too wide. We want just a natural looking bridge. So this is pushed up through the radix bone cut, and then it gets fixed to the caudal septal extension graft with two 4 PDS sutures. So this recreates or creates the dorsal augmentation. So you can see we pull it up, we suture it with a couple 4 PDS sutures, and then now the L strut is reconstructed in a new position, an elevated position, which gives the augmentation effect. Here you can see the graft above and the septum below. So you can see that there's how much the dorsum's been elevated because it's been pushed up probably a centimeter. And this is from below. So now you can see the bones are narrower. Now we have to fix the graft to the nasal bone. So I make a small stab incision and I take a 16 gauge needle, a couple of them, and I drill a hole across the bone and pass a 4-row PDS suture across both bones. Then the back end of that suture needle gets passed through the stab incision. We grab it and then we pass it through the graft, caudal to the bone. So what this does is once this is cinched down on the left side, it literally pulls the graft into position and holds it there against the nasal bones. So it's very, very solid fixation so the graft does not shift out of position. And that suture will just dissolve. We suture the medial crura to the caudal septal extension graft. And then, as in Asian patients, we do most of the time, we put in a shield graft with lateral curl, or in this case, I use a buttress graft to stabilize the cranial margin. And then we camouflage with perichondrium, and then we put in the articulated rim grafts into the pockets. So that is for the tip, and that's the nose at the end of the procedure. Then here she is a year post-op. We can see improved dorsal aesthetic lines, improved tip projection, and a modest elevation of the radix. As you all know, Asian patients don't want a large radix augmentation. They just want maybe 5 millimeters in this patient, just so that she can get some improved contour on the front view and also wear her sunglasses. Here's her 3/4 view. Here's the base view. And on front of you, you can see that there's improved dorsal aesthetic lines, but you're just looking at the nasal bones, no implant of any kind. This patient had a very low radix as well as an anterior positioned globe. So she has some degree of ptosis or proptotic eye. So we carve our subdorsal cantilever graft, make it very narrow in this case, and then we fix it to the caudal septal extension graft. And then here she is 2 years post-op. You can see how the radix and the tip has been projected, expanding her thick skin to create contour. And then I also use structure and preservation for secondary rhinoplasty. We do a lot of revision cases in the Asian patients who have implants and then have the implants removed, and then we replace with the subdorsal cantilever graft. So this patient comes in, her silastic implant is off midline, and it frequently is a problem for her. And so she also has an underprojected tip. So on her, we use a subdorsal cantilever graft. So I harvest the seventh rib and a segment of the eighth rib. We take out the implant, and then we do our high subdorsal cut caudal septal replacement graft with native perichondrium attached, and then our subdorsal cantilever graft with native perichondrium attached. And then the shield graft with articulated rim grafts. So here you see the implant coming out, and that's the defect. She has a very low dorsum once the implant comes out. So we dissect between the medial crura, do the high subdorsal release with a straight scissor to release the midvault and the bones. Then we take an osteotome, in this case, 2 millimeter osteotome. We make a radix bone cut from below. And then we do bilateral lateral osteotomies after a wide subperiosteal dissection because the bones need to be moved in at least 3 or 4 millimeters anteriorly. So this is a low to low lateral osteotomy. Here I'm doing the transverse bone cuts from below. So I'm just freeing up the bones from below. Now the whole bony vault's completely mobile. I can take an instrument, put it up there, and we take our subdorsal cantilever graft with all of the perichondrium attached. There's the gap I created. And then the graft goes, we put in our caudal septal replacement graft to suture in a notch in the nasal spine. So this is our caudal support, and then you can see the subdorsal cantilever graft with all the perichondrium attached. That's really important. That allows for very quick fixation to the bones. And then we suture that graft to the caudal septal extension graft with a couple foro PDS sutures, and that leftover perichondrium gets wrapped around the connection. And then we do our fixation, as I showed before, passing the foro PDS suture transnasally. And then we bring it back through that same hole, suture it to the caudal subdorsal cantilever graft, bring it back through the hole on the left, and then tie it in position. And that really holds the graft in a very stable fixation point. And then we move the medial crura anteriorly by advancing the base anteriorly. This will open the nasolabial angle, and then that's with the shield graft in place. You can see good projection and good dorsal height. There's the graft endoscopically above, and then the septum below. We just leave the septum there. In this case, we did remove some of it. And then here she is a year post-op, improved dorsal aesthetic lines. Her dorsum is in better position now, and her projection is increased 3/4 view, base view, and then the close-up frontal view. Another patient with an implant in her nose. She had Gore-Tex. She had a lot of asymmetries, and the skin had thinned over the dorsal or the implant. So you can see the depression there. She had about 5 separate pieces of Gore-Tex, all removed. And then that's the actual defect requiring the repair, but the bones were still intact. So I made a notch in the spine, put a caudal septal a replacement graft, and then we have our subdorsal cantilever graft. We do all the bone cuts, push the graft in through the radix bone cut, fix it to the caudal septal extension graft, advance the base anteriorly, and then put in the shield graft with the lateral crural grafts and then the articulated rim grafts. And then here she is 8 months post-op with good projection, reestablishment of dorsal height, 3/4 view, base view, and then close-up frontal view. So that's no implant, no grafts, everything's underneath the bones. Another patient with a DCF graft on the dorsum, which left her with a very asymmetric and depression in the left side of her bridge. She's underwent multiple prior rhinoplasties and then had an infection resulting in a drainage to the right side of her tip with a very severe stenosis of her left nostril. So in her, we use the 9th rib and the 8th rib because we need to protect the grafts. You can see the depression in the left side of her bony vault, where she said it occurred over about 4 months, and it's probably because part of the DCF graft dissolved or resorbed. And after removing the DCF graft, she had a very, very low deformed bridge. You can see on frontal view, there's nothing there. It was completely flat across her midface. So we put in a caudal septal replacement graft. We take the 9th rib and we notch it, leaving all the perichondrium attached. You can see even muscle attached to it. We place it through the radix bone cut, put in some lateral crural replacement grafts. In her, I use lateral construct grafts because I really need to fix her stenotic left nostril and open up her airway, which was her main complaint. Take a composite graft from the left ear and use this in a hinged fashion to reconstruct the nasal valve. And then here she is 10 months post-op. She has much improved dorsal aesthetic lines, good projection in her tip, 3/4 view, base view. You can see the left nostril is now open, and then the close-up frontal view. So I use irrigation catheters a lot in patients with infected or exposed implants, and these are 22 gauge catheters that are placed into the surgical site and left in place in most patients for 5 to 7 days. This is a paper we published on 3,084 cases using antibiotic soaks and or irrigations. The antibiotic soaks are used as well once the catheters are removed. We found an infection rate that was essentially zero with the irrigation catheters. That's due to the use of this combination of soaks and irrigation catheters. I leave the native pericardium attached to these cartilage grafts in high-risk patients to protect the rib. It acts as an interface to allow vessel ingrowth and rapid incorporation into the tissues. Here's a patient who has an exposed implant in her right nostril for over a year. So we remove the implant. It's a silicone implant. We harvest her rib, leave the pericardium attached. She's in her 60s, so the pericardium is very important. You can see how we leave it attached. Then we put in a little dorsal graft. And then we put 3 irrigation catheters in. So I did immediate reconstruction at the same surgery that we removed the implant. So that's risky. So we put the catheters in, and here she is on day 7. You can see here with the catheter still in place. And then here she is a month post-op. And then here she is a year post-op. So single stage reconstruction, removing an infected implant and reconstructing at the same sitting. But the key here is the irrigation catheters and the pericardial covered grafts. When we do complex deformities, we use a lot of hyperbaric. We do this in all revision cases. The hyperbaric is 2.2 to 2.6 atmospheres pressure. We also use an anti-inflammatory diet. This is a last case I'm going to show. This is a patient who had a necrosis of her supratip skin due to excessive debulking. We do a needle stick test, and you can see that first needle, there's no bleeding. So that's a big problem. So what we do with that particular site is we inject nanofat into that area to recover the vascular supply to the skin. That there is good, but right in the middle of that area is a problem. So we put a little nanofat, and then we bring the patient back a couple months later after the nanofat it takes effect in combination with the hyperbaric. And then we harvest the rib with the attached native pericardium, put a caudal septal replacement graft, shield graft, articulated rim grafts, a little more nanofat, some composite grafting, and here she is a year post-op with good projection, 3/4 view, opposite lateral view, 3/4 view, base view, and close-up frontal view. You can see the necrotic area is even improved with the nanofat. So structural grafting using rib cartilage is the key for the structural portion of our Asian augmentation rhinoplasty cases. I really enjoy the use of the subdorsal cantilever graft incorporating preservation techniques in the Asian augmentation rhinoplasty patient. I like this technique quite a bit. And then, of course, we preserve the use of structural grafting in our nasal tip to provide maximal tip projection and preservation of the positioning of the alar margins. All these techniques are shown in their recently released 2-volume structural preservation rhinoplasty book. Dr. Saban and Dr. Goxel are also co-authors and co-editors. This is available at Quality Medical Publishing at their website. This is my 3-volume textbook, which you can get at toriumirhinoplastybook.com. And then we invite all of the participants to our Marina Medical Cadaver course, which is December 11th through 13, 2026 in sunny South Florida. Both Dr. Saban and Dr. Goxel are faculty as well as many other distinguished faculty members. And then, of course, we have the Structural Preservation Rhinoplasty meeting in Istanbul, November 19 to 21, 2026. The primary organizers are Dr. Chalker and Dr. Goxel, and of course, um, Dr. Saban and myself will be there, as well as many other very important structural preservation rhinoplasty surgeons. And thank you very much for your attention, and thank you for the invitation to present today. And I look forward to seeing all of you in Bangkok in July. We'll have a lot more information that we can provide to you at that time. Thank you.
Okay, thank you very much, Dr. Dean, for this very informative lecture. This is rather very new to our field of doing patient structured augmentation rhinoplasty. Let me see if there are questions here. So far, not. I have a few questions myself. What if you see a mucosal tear inside the nasal cavity, the area way deep? How would you manage that? A nasal tear, just a nasal mucosal tear. Let's say, for example, that is septum. How would you manage that?
Okay, so first of all of the grafts are covered with perichondrium. Because the grafts are covered with perichondrium, the mucosa will surely heal over tears. If it's a larger tear, I use what I call a silastic healing chamber. I have a very special type of silastic sheeting that has Cylon in it. It's highly adherent to the tissues. I place it over the mucosal tissues and suture it in place and leave it there for a month. Invariably, all these areas heal very nicely. We'll also, if it's a really big mucosal issue, I'll put perichondrium between those flaps, inject nanofat, put the silastic healing chamber on, and have the patient do a minimum of 10 90-minute hyperbaric sessions at 2.0 to 2.4 atmospheres pressure.
Okay, there is a question here from the Philippines. If have you ever experienced warping of the dorsal push-up technique? The grafting.
I had one patient who had a little bending, which was easily corrected, but in most cases, the reason why bending doesn't occur is because I minimally carve the grafts. And because they have pretty much all the pericardium attached with minimal carving, there's no manipulation of the cartilage, so the risk of warping is very low. You saw the grafts I used there. Most of them are relatively intact, meaning they're minimally carved. And if you know rib, and you know that you minimally or no carving of that graft, there's no opportunity for it to warp.
Okay, there is a question here from, I think, Thailand, I'm not sure. Hi, doctor, the graft is sutured together with the nasal bone. So his question is it sutured to the nasal bone? For deviated septum, can this procedure be done at the same setting? Or deviation required correction first before the surgery?
Okay, so the first part of the question, or the deviation part, the deviation is irrelevant because in essence, you are replacing the entire L strut with a caudal septal extension graft and the subdorsal cantilever graft. So that is what's very nice about this technique. You can literally remove the entire cartilaginous septum once the L strut is reconstructed. And I've done that in many patients who have severe septal deviations, where the L strut is created with the caudal septal replacement graft in combination with the subdorsal cantilever graft. And once that's established, the septum itself can be removed because it becomes irrelevant. What was the other part of the question?
Do you suture the graft to the nasal bone? I think
Yes, so the
you
graft is sutured to the nasal bone by making a hole with multiple 16 gauge needles. I drill a hole through the nasal bones. Then through that needle, as shown in the video, I pass a 4 PDS suture. So imagine a suture that's going through both nasal bones, through the bony vault, goes back through the skin, goes through the subdorsal cantilever graft in a more caudal position, goes back through the hole on the left side and gets tied. So what it's doing is essentially pulling the graft tightly against the bony vault to hold it in position. And because the graft has perichondrium attached to it, it ossifies in position very quickly, probably within a month.
Okay. It would be nice, I think, if you will be doing performing this procedure and then cut over. I hope we can provide an Asian nose, Eddie, for Dr. Dean Toriumi, if ever. Yeah.
Yes,
Yes.
we
Yes,
try.
if Eddie brings or gives me a nice piece of rib cartilage, I will execute this technique in the cadaver in Bangkok.
Okay.
Thank you,
And
Dr.
We will
Toriumi.
I'll show you all the little nuances.
Okay. Yeah. All right. Still time, Eddie, for still plenty of time. Normally, well, this is just a practical question. Can you, of course, this is not under general anesthesia because of the rib cartilage. Am I right? General
Yes.
anesthesia. So usually, how long does it take for a novice surgeon, if ever?
So for me to perform a subdorsal cantilever graft augmentation using rib and structural reconstruction of the tip, it's less than 4 hours, somewhere between 3.5.
Okay, that was that that is fast. Okay, okay. Yeah. So regarding the rib cartilage that you harvested, it is always 8 and 9. Am I right? Did I hear it right? 8 and 9 rib.
So it depends on what's needed. So for instance, if the patient needs a caudal septal replacement graft, subdorsal cantilever graft, shield graft, and if the patient's age is older, meaning greater than 50, I will use 8 and 9. If it's a patient in their 40s to 50s and they don't need a subdorsal cantilever graft, if they just need grafting in the nasal tip, such as lateral construct grafts, in those situations, based on the shape of the rib, I'll use either 7 or 8. So it depends on the particular indications in each case. And also depends to a great extent on how wide the dorsum needs to be based on what the patient's requests are. So all of these things are keys in determining which rib I use. I palpate the chest. Some patients have a curved ninth rib, and that makes it unusable. And if that's the case, then I'll take 7 and 8.
Okay. I have a question, by the way, personally. How would you screen for a rib that may seem, because normally we don't request for CT scan or any radiologic examination, because sometimes when we harvest the rib is completely ossified. Really, what do you do to detect such deformity?
So all
Do you
patients,
do CT?
no,
Yeah.
I don't do any imaging, no imaging. What I do is when the patient is asleep, I take a 22 gauge needle and I palpate with the needle the status of the rib. I've done this for over 30 years, so I'm very accustomed to this. So by simply palpating, meaning poking the rib with a 22 gauge needle, I can map out the exact segment I want to harvest, whether it's 7, 8, or 9, a combination of those. I identify any areas of calcification. I identify the osseous junction, and then I site my incision based on those parameters. That way there's no surprises. I know, like in sometimes, I'll palpate the right chest and there's too much calcification. I go to the left chest, I find a piece 3 centimeters, 4 centimeters, that's good, and then I go after that rib.
Okay. There is a question here. Does the subdorsal, I think this is from the Philippines, does the subdorsal cantilever graft also serve as a spreader graft?
Yes, it does. What it does is it splays the upper lats and opens the airway. So it improves the breathing, the based on the shape of the graft. So it really does a good job on the nasal valve, opening up the nasal valve.
Okay. This is my personal question. If you do the subdorsal cantilever graft, do you still do if ever, harvest the septum, a central septum, if there is still a septum left, or you just leave it intact?
Usually I just leave the septum and work around it. Because
Okay.
I don't need the septum because I have the rib and I use the rib, and
Rib.
the septum in Asian patients is pretty weak, so it doesn't provide much help anyway. So I just leave it there. And I don't use
Okay.
ear. I don't use ear in these patients unless I'm doing a composite graft.
Okay. We use ear a lot, especially for tip graft, for the contour. Okay. Well, okay. Any more questions here? Okay.
I think there's no more new questions, Dr. Yap.
Okay. Yeah. All right. So, okay, one last question. One last question. Regarding the rib that you may harvest, let's say, for example, you get the best rib, and you can get only because in my practice, I usually it's like this. When I get the rib cartilage, that is the best rib cartilage, that is the most slightly ossified. Usually, I use DCF for that, dice cartilage and fascia. Now, if I'm able to get a whole rib, then as much as possible, I use a whole rib for the dorsal. So, what if, for example, you get, presuming that you thought that it is a good piece of cartilage, and then when you take it out, some parts are heavily ossified. So, what what do you do?
I have two piezotomes, and the piezotome is invaluable to me. Um,
Okay.
if the chest wall is completely calcified, no cartilage, I can still do the operation if I have my piezotome. With the piezo,
Okay.
I'll remove the rib segment, I'll carve the grafts, I'll make holes and suture it. So I actually prefer ossified rib, maybe 50% ossified because it's stiffer and stronger and it won't bend or warp. Cartilage I
Okay.
don't like is soft cartilage. That's the only one that doesn't work. That's the only contraindication to this procedure is soft rib cartilage because, well, in that case, then I have used the bone. So I'll use a osteocartilaginous segment. So I take a segment of the eighth rib with bone and cartilage. So I take about a 4 centimeter segment of bone with about a 1 centimeter segment of attached cartilage. The bone is burred down, leaving as much pericardium as possible, and that's what gets placed underneath the dorsum. And then the cartilaginous part is what gets used to suture to the segment that's used for the caudal septal replacement graft. So an ossified rib is not a contraindication to this technique. And in fact, it's stronger, stiffer, and works well in this technique.
Okay. Uh, all right. Just to let you know, in our way of doing rhinoplasty, we always do structured rhinoplasty with a tip projection surgery, and after which we put in the graft, which we think is a graft that will blend the new dorsum to the new tip. Now, in your technique, so you first do the dorsum, and then finally, it's the other way around. All right.
Right.
Okay. We have a question here from the Philippines. She is asking from Dr. Joyce Regalado. She is asking how do you estimate the height of the subdorsal cantilever graft pre-op or during surgery?
Okay, so
How high?
so you can raise the dorsum up to 6 millimeters. The limiting factors are the release of the bony vault and middle vault. What happens is once you hit 5 millimeters, the middle vault is under such stress and tension, it can break apart. So what I do is I put fixation sutures, 4 of them. They're 4 OPDS sutures that are going across the top of the middle vault from upper lat to upper lat. So I do that before I put the graft in. Then I do the lateral keystone release. I release the piriform ligament. I widely dissect the periosteum. And in some patients where I want a lot of augmentation, I even cut the periosteum to allow more release. Then the upper lats will move forward without breaking apart because of the tension. So maximal augmentation using this technique is really 6 millimeters. What you can do is raise the bones to the location you want, get the mid vault to a best position as possible, and if you need to, you can put a small supertip graft over the supertip area to get to exactly where you need to be. The key with this graft, though, is the elevation of the bony vault because that's where I prefer not to have any grafts. I want just the bone up against the skin. And that's why I believe the subdorsal cantilever graft is a good technique for Asian augmentation rhinoplasty. I developed it for that particular patient population, and it works very well. I understand that these methods are contradictory to what's typically done, which would be a silastic implant or DCF over the dorsum in combination with, ear grafting for the nasal tip. This is different from what's typically done. I'm not saying it's better, but it works well in my hands.
Thank you very much, Dr. Dean. So I think we can wrap up this session. Eddie, what do you think?
Yeah, thank you very much. I think we have about 60 minutes from the presentation to the question and answer. Again, thank you very much, Dr. Dean, for his precious Sunday morning, and Dr. Yap, and the rest of the 240 attendees for tonight webinar across Asia, from Europe, even from Australia, which is right now is almost midnight. It's quite a great achievement for us, which is above almost 50% from our registration. So thank you very much, everybody. And this is the upcoming Nose by Fest coming in Bangkok on July 17 to 19. I think now it's a great task to get the rib as Dr. Dean requested. So I think that will be my task to bring the best materials for Dr. Dean and Dr. Saban, Dr. Goxel, and even Professor Yong to do a great demonstration. So without further ado, this is the dates.
Okay.
Please register the dates 17 to 19. And we have 2 days of presentation in the hotel. And the final day will be a demonstration by 4 gentlemen and also a cadaver hands-on by participant to register. So log on the www.fest.my and register, especially for the hands-on, which is truly limited seats. All right. Thank you very much, everybody. Is there any parting words from you, Dr. Dean, Dr. Yap?
Okay.
Yeah, I would
Let
just,
me recap this
go
session.
ahead.
Okay. Just let me recap this session. As you see, last March 8, we have Dr. Saban talk on the basic principles of dorsal preservation rhinoplasty, moderated by Dr. Kitakorn. Now, this time we have Dr. Dean with us, who just completed this very informative lecture on dorsal push-up and structural rhinoplasty, which is actually aimed at Asian rhinoplasty noses. So we can see that there is a common goal to make a nose that preserves the ethnicity and a nose that restores the harmony of the base. With that, thank you, Dr. Toriumi, Mr. Eddie Liu, the organizer of the FATS event, and to the about 240 participants around the world, and to Ms. Daphne Wong, the head of the support group of FATS. At this point, Dr. Dean, you might have some parting words.
I just wanted to again thank you, Dr. Yap, and then Eddie for the invitation. I've never been to Bangkok. I'm looking forward to it. I'm looking forward to a very educational and outstanding meeting. And I again encourage all of you out there participating in this webinar to come. And we have a lot to teach you both in structure and preservation. I think will be very, very beneficial to add these techniques to your surgical armamentarium.
Okay, thank you very much,
Okay.
Dr. Dean, Dr. Yap. Okay, with that, we shall close the session.
Okay.
Thank
you
you.
very much. Thank you again. Thank you.
Thank you very much.